respect everybody's time. I'd like to welcome everybody to the second annual Pediatric Neurosurgery Educational Forum put on by the AANS CNS section on pediatric neurosurgery. The purpose is to deliver topics on things that we see within pediatric neurosurgery by experts in the field and discuss education and discuss controversies and really impart the wisdom they have gained over the years. With that, I'd like to welcome everybody to our second lecture in this series. And for a man that needs no introductions, our featured lecturer for this lecture will be Dr. Bermans Iskandar, who is the professor of neurosurgery and director of pediatric neurosurgery. He has served in multiple roles in all of our various sections and national organizations. He is a world-renowned expert on folate, myelomeningocele, and spina bifida, and a very well-spoken, knowledgeable person on this topic. Without further ado, Dr. Iskandar, please take it away.
Thank you, Jeff. It's my pleasure to give this presentation as part of an effort of the joint section to enhance the education of its young surgeons, APPs, and staff. If there ever was, see, my slide's not, okay. If there was ever an anomaly that defined us and what we do as pediatric neurosurgeons, it's the myelomeningocele. The management of a myelomeningocele or spina bifida goes beyond a simple surgical repair and encompasses lifelong challenges. These include shunt problems, coexisting anomalies that complicate the diagnostic dilemmas, prevention, long-term multi-system disability with ethical and legal implications, and various long-term surgical and medical needs, and all based on an embryologic and scientific complexity that has challenged even the best in the field. Today, I'll start with a brief historical, embryological, and anatomical perspective, then spend the rest of the time discussing the evolution of both the clinical care as well as the science over the past decades. I'll end with a succinct overview of the challenges and future prospects. After the presentation, Dr. Simpson, Salehi, and Sribnick will provide us with case discussions that will hopefully highlight critical areas of clinical care that have been especially challenging and given the best of us some gray hairs. Obviously, we cannot address all issues in 1 hour, but we'll try to hit the major ones. What we'll discuss only minimally is prenatal closure, as this, we believe, is a topic that requires its own lecture and discussion. Although descriptions of spina bifida date back thousands of years, from the days of Hippocrates and Galen, it is Nicolai Stolp, official city anatomist and mayor of Amsterdam, and pictures in this famous Rembrandt painting, who first used the term spina bifida in his book Observationes Medicae. In the late 1700s, Dr. Benjamin Bell declared spina bifida to be the most fatal disease in infancy because of unavailability of treatment. Most patients died of hydrocephalus or infection. In other words, surgery wasn't successful until the introduction of aseptic surgical techniques in the 1870s, after which time the multi-layered myelomeningocele closure was introduced, with the earliest formal description written by Charles Fraser, whose technique was still used today. First and foremost, it's important to note that NTDs are not limited to myelomeningoceles. Depending on what part of the neuroaxis it affects, a neurulation problem can result in anencephaly, myelomeningocele, craniorhexischisis, and others. This is a depiction of primary neurulation. I'm going to activate the video again in action in a xenopus model, and note the open defect here that results because of the neural tube lack of closure. Here's what the myelomeningocele looks like in profile and a cross-sectional schematic. The unneurulated segment is called a Plecode, and the Plecode is attached to membranes that keep the fluid in. And unless there is rupture or leakage during labor or delivery, the infant is born with a fluid-filled sac. The covering of the sac is an epithelial membrane that should be removed in its entirety during closure, because otherwise epithelial elements get trapped, leading to dermal inclusion cysts, dermoids and epidermoids. Once the membrane is resected, the fluid leaks out, and the rest is a layered closure. Okay. So this starts with rolling the Plecode into a tube. This is presumed to decrease the risk of tethering by hiding the rough surface of the exposed Plecode. It's not because it's going to give it more function. After which time, the dura is dissected off the edges and closed into the midline. So this is what it looks like before the skin closure. Now, there are many techniques of skin and fascia closure. The one that I will describe here is the one that I've adopted in my practice and which was developed by a group of plastic surgeons in the 80s, predominantly for large defects. This technique comes with distinct advantages for skin healing and fascial coverage, and over the years, I found it straightforward enough to use even on small defects. Briefly, it consists of bringing together the latissimus dorsi and the gluteus muscles along with the skin, thus achieving a thick, healthy closure with little of any vascular compromise to the skin. Here are examples of such repairs. In most, I find it best to use a subcuticular closure and steri strips, as this has less chance of skin necrosis. But again, there are many ways to do this. So the technique I describe relies on the fact that the major back muscles, the lats and the glutes, insert on the lumbosacral fascia, which means that when you lift the fascia, you end up right under these muscles, a very straightforward maneuver. Importantly, however, the vascular supply of these large muscles come in laterally through the belly of the muscle. And since the skin gets its vascular supply from the underlying fascia, undermining the fascia and muscle instead of the skin spares these vascular elements. So you can see here how the vascular supply of the muscles come through the belly laterally. So by undermining the muscle, you're not going to compromise this supply. Whereas here, this is how the skin is supplied. So by going under the skin, you're presumably decreasing its vasculature. So you're literally bringing together all these layers of the midline, keeping the closure thick and healthy, like so. But regardless how you close myelomeningocele, we all encounter the same long-term issues. So what were the important advances that have occurred in the last few decades? First is the decision to operate. John Lorber was a professor of pediatrics at the University of Sheffield in England. In the 1980s, based on disappointing long-term outcomes in treated spina bifida patients, Lorber started advocating for supportive, non-surgical care for those who present with severe disease, and he defined severe disease as hydrocephalus and high lesions. Other neurosurgeons followed suit, including in the United States, and this was termed selective treatment. But selective treatment was met with great disapproval among the US pediatric neurosurgery community, and Dave McClone eventually published his results showing that actually spina bifida patients did better if treated. Anecdotally, Dr. McClone shared with me that he showed Professor Lorber his results at a conference and that Lorber did not believe the data and called him a liar. He added that despite that, they remained friends. A first example of how our field developed piecemeal by trial and error and by sheer strength of character and purpose among our founding fathers. These controversies were not isolated to spina bifida. In fact, concurrently, the US was going through ethical and legal battles regarding what is to be termed Babydoll rules. The Babydoll rules were led by Surgeon General C. Everett Koop and President Ronald Reagan, who stipulated that life of a disabled child can only be withheld under 3 circumstances: coma, terminal illness, and the provision that such treatment would only prolong dying, and when treatment is futile and inhumane. The Surgeon General made it a point to use Jane Doe, a spina bifida child, as a perfect illustration. The law was signed by President Reagan as an amendment of the Child Abuse Prevention and Treatment Act, CAPTA, which was exceedingly unpopular in the medical community, who rather than strict legal rulings recommended a procedural approach to be handled by ethics committees, with the ultimate decisions being in the hands of the family and caregivers. The AAP acknowledged that the Babydoll rules existed, but maintained that the inclusion of in the treating physician's reasonable medical judgment accommodates standard practice. While court actions have been sought in many cases, these have in general provided guidance, and there has been no case in which a medical caregiver or family member was found liable for withholding treatment, which was tacit approval of the AAP interpretation. The main reason for this, however, is that the Babydoll rules don't really apply to physicians and hospitals, but instead to state health departments. Regardless, although these controversies continue to date in various medical scenarios, these rarely include the care of the newborn with spina bifida, with universal agreement that these children should be treated, unless, of course, they're accompanied by other major anomalies, such as a fatal cardiac defect. The second paradigm shift came with the invention of the one-way valve, thanks to John Holter. John Holter was a tool maker and father of a spina bifida patient, Casey. And this, interestingly, was the first time that silicone was used in the human body. Remarkably, prior to the invention of this valve, 9% of children with hydrocephalus survived to age 10, and all survivors were developmentally delayed. And after 1958, 86% survived to age 16, and more than half of them had normal intellect. And since then, more advances were introduced in the care of the shunted patient to optimize their quality of life and decrease the risk of death from shunt malfunction. Namely, it's been observed that more than 30% of shunt malfunctions have no ventricular dilatation. Death from shunt malfunction is improved through education. Introduction of low or no radiation diagnostic studies has improved the overall quality of life and the risk of cancer in these patients. Prenatal closure decreases the incidence of hydrocephalus, and Chiari symptoms are treated with shunt rather than
They said
decompression.
30 and 15 minutes.
Can you guys please mute yourselves? And finally, ETV CPC decreased the rate of shunting. And these discoveries led to another paradigm shift, the understanding that spina bifida is not a progressive disorder. What do I mean by this? Well, unlike diseases such as multiple sclerosis, Alzheimer's disease, Parkinson's, progressive spastic paraparesis, spina bifida is a static anatomical defect. So when the child presents with worsening function, such as leg weakness, bladder incontinence, cognitive decline, that indicates that there is a complication. Shunt malfunction, syringomyelia, tethered spinal cord, etc., which may benefit from surgery. And the purpose of surgery here would be to halt the deterioration and in some circumstances, possibly even improve function. The third paradigm shift is pure and simple introduction of clean intermittent catheterization, which overnight allowed patients with neurogenic bladders to become socially continent, a very significant advance. Two major advances that has happened in our professional lifetime were related to prevention. Prenatal closures decrease the risk of developing hydrocephalus and Chiari-2, so in this sense, it's a preventive intervention. As I mentioned before, however, fetal repair will be given its own lecture in the future, so we'll not discuss it here. However, the major preventive measure that has revolutionized the field of neural tube defects is folate supplementation. Folic acid is a synthetic molecule that activates the folate pathway to provide nucleotides for DNA and RNA and methylate. Since introduction of folate supplementation and later food fortification, there has been a significant reduction in the prevalence of all NTDs by about 70%, a neurogenetic triumph. Of importance, of course, is that since neurulation occurs in the first month of gestation, meaning that a woman learns she's pregnant after the neural tube has formed, the official CDC recommendation states that any woman of childbearing age who's sexually active should be on 0.4 milligrams of folic acid per day, regardless of birth control use. In high-risk pregnancies, meaning women with spina bifida or women who've already had an affected pregnancy, the dose is tenfold or 4 milligrams per day. And these show the trends by year and by country of decrease in NTD prevalence over the past 2 decades. Okay. So with all these improvements, what are today's survivors like? Well, their IQ is average, and 50 to 60% of them ambulate freely, attend regular classes, and live independently with no adaptation. But it, of course, all depends on the level of the defect, the higher ones being associated with a worse prognosis, and of course, the presence of hydrocephalus. Please note that this graph is old, so it's important that we analyze more contemporary data. This is a hint for future research. But as you all know, challenges remain. First, 40% of shunts don't last a year, and the majority fail within 5. The spinal cord tethers from postoperative adhesions, a problem that leads to neurologic decline and recurs in many. There is still a large segment of the population that cannot live independently, ambulate, or be employed. And even the ones who are independent have difficulty transitioning to adult caregivers who are not familiar or comfortable with this patient population. Folate prevention policies are difficult to apply in many developing countries especially where NTDs are endemic. And of course, some children still die early, often from complications of hydrocephalus and chronic disease. So led by Jeff Blount and the CNS and PEDS section guidelines committee, spina bifida guidelines shed a bit more light on the present state of our clinical care. Unfortunately, the only level 1 evidence that they've identified related to the MOMS study, which showed that prenatal repair decreased the risk of hydrocephalus. Beyond that, level 2 evidence showed that prenatal repair may improve the children's ability to ambulate while increasing the risk of recurrent tether cord and inclusion cysts. After postnatal closure, there was no sufficient evidence to confirm that closure within 48 hours decreases the risk of infection. And similarly, there was no evidence to conclude that ventricular size and morphology impact neurocognitive outcome. So the fantastic duo, Brandon Rock and Jeff Blount at UAB, have led the field in spina bifida transition of care in the past few years and identified the high prevalence of apnea in these patients and asked whether untreated apnea in growing children affects neurocognitive development. Which brings me to transition of care. This is a huge topic in its own right, and of course not limited to spina bifida, but covers many other complex congenital anomalies. The UAB team has identified 5 essential goals to any transition: education, bowel program, as well as tailored protocols or goals for patient, family, and provider. I would refer you to the growing literature on the topic, as well as the commitment to all our societies to cover this topic and support the initiatives. So considering the complex nature of this multi-layered disease, we're left with a number of clinical challenges. Non-neurosurgeons, caregivers, need to optimize the indications and sensitivity of CMGs to better manage bladder function and try to identify tether cords early. Although the vast majority of spina bifida patients have social fecal incontinence, problems with who manages the bowels and how remain a major source of consternation to those who are in the process of transitioning. And scoliosis is a significant issue because unlike idiopathic scoliosis, it's associated directly or indirectly with cord tethering. And so the orthopedic surgeons get caught up with the complicated nature of patients with recurrent spinal cord tethering, along with complex timing and difficult and unpredictable neurological exam. The neurosurgical challenges include those associated with prenatal repair and type of repair, namely, what are the indications for fetal surgery in those who do not fit the criteria of the MOMS study? And how does fetoscopic repair fits in? This, again, is a topic of future discussion. What we will discuss today, though, via case presentations to follow this lecture is treatment of hydrocephalus in the spina bifida newborn that would be discussed by Dr. Salehi, what to do with the symptomatic recurrent tethered cord patient by Dr. Sribnick, and then syringomyelia and the Chiari-2 malformation that will be discussed by Dr. Simpson. The science underlying neural tube defects is even more complex than their clinical features. This includes folate biochemistry, genomics and epigenomics, genetic mouse models, which, by the way, can have responsive or resistant mouse models to folate, in vitro NTD modeling, developmental animal models, folate receptors, cell polarity and shaping behavior, and epidemiology. And I will only cover some of these because of the limitations of time. I just want to point out, is a picture that came from one of our own researchers at UW that shows rosettes that simulate a neural tube formation in vitro. Very, very interesting. So what do we know about the science of neural tube defects? First, while it's familial, neural tube defects have both genetic and non-genetic factors. In particular, there is genetic polymorphism in genes that code for folate pathway enzymes and in genes that control cell polarity, which I'll discuss later. The main challenges, however, include the fact that no gene mutation consistently predict NTDs in humans, and there's not one gene that defines NTD. Second, no mouse model consistently reproduces human NTD. But I think thirdly, and most importantly, is that 30% of NTDs are folate resistant, which means they do not respond to folate supplementation. A role for inositol has been hypothesized in animals and tested in human studies, but the data are not as clear as folate. But this group does not respond to folate. And while people are looking for causes of folate-resistant NTDs, folate-responsive NTDs continue to be challenged. First, we should clarify the different forms of folate supplementation. Folic acid is a synthetic and inexpensive form of folate that has to be converted in the body to the active tetrahydrofolate form via two consecutive enzymatic reactions mediated by dihydrofolate reductase. The problem is that the monoglutamates, or folic acid, are primarily metabolized in the liver and not in the gut. And the liver is not a very good source of DHFR. But what that means is that often the conversion is not complete, and any accumulation of the synthetic form of folic acid can be potentially harmful. Accordingly, there's no understanding of folate dose needed for NTD prevention, and it's likely that the dose depends on a person's metabolic status as well as baseline folate levels. There are many theories, but three that have been most discussed. Because the increased risk of autism in the general population has coincided with the beginning of folate supplementation, some have hypothesized that excess folate may be one of the causes of autism. The literature got a bit more confusing later on, when in some instances, folic acid was shown to actually decrease the rate of autism. To make matters even more complicated, it's well established that the folate receptors can create autoantibodies, and early studies suggested that these autoantibodies correlate with NTD pregnancies. Further studies showed that this may not be the case. However, a link seems to exist between autoantibodies and autism. Nevertheless, the issue remains controversial, and there are strong opinions on both sides. The lesson here is neurosurgeons don't own the copyright on strong opinions and controversies. Third, de novo mutations were found to occur in both folate-deficient animals as well as animals with high folate levels compared to normal levels. And while there are many unknowns regarding the risks of high folate, it all comes back to the inverted U or bell-shaped curve. So unlike what Mae West may suggest, too much of a good thing may not be wonderful. In fact, Paracelsus, who's recognized as the father of pharmacology, stated emphatically that all things are poison and nothing is without poison, only the dose permits something not to be poisonous. And over again, whether it's biological processes, economics, social sciences, and all other fields of study, an inverted U or bell-shaped curve emerges, a Goldilocks phenomenon, not too much, not too little, just enough. So in folate biology, bell-shaped curves have been recognized in various contexts, the most convincing of which is one we've identified in studies of spinal cord regeneration, in which we found maximal axon regeneration occurs at an optimal dose of 80 micrograms per kilo, and less regeneration occurs at lower and higher doses. Importantly, no toxicity has been identified. But with NTDs, the optimal dose has not yet been identified, and current supplementation recommendations are based on single-dose studies. If we were to take it further, though, we might wonder whether multi-generational folate supplementation has cumulative effects with potentially deleterious consequences. Regardless, until further data arise, the benefits of folate supplementation, as currently practiced, far outweigh any potential risk of harmful consequences. Next, it bears to understand how cellular behaviors lead to neural tube closure. Planar cell polarity refers to the coordinated alignment of cell polarity across the tissue plane. This phenomenon is controlled by the PCP molecular pathway, which integrates global directional cues to produce locally polarized cell behaviors. This is what controls the folding of the neural tube. In this case, cell wedging and intercalation occurs in each cell, which change the behavior of the sheet of cells, causing it to fold. Planar cell polarity is not limited to neural tube closure, but is also involved in gastrulation, ear patterning and hearing, and other cellular processes. In these videos, which I'll activate here, from frog embryos, you can see neural tube closure across the entire neuroaxis. In this case, leaving a neural tube defect in the part of the tube that failed to close. Finally, I mentioned before that NTDs have both genetic and non-genetic factors. In this context, it's important to know that NTD is not a folate deficiency disorder. Instead, folate deficiency is a risk factor for NTDs, but only in the presence of a predisposing genotype. The most well-recognized genetic factors are planar cell polarity genes and folate pathway genes, which include genes that code for folate enzymes and folate transport. Notably, folate pathway gene polymorphisms are very common in normal population. For example, up to 25 to 40% of the American population has a mutation in the C677T position of the MTHFR folate enzyme gene, and 3 to 5% are homozygous. On the other hand, environmental contributions to NTDs are many and include diabetes, anticonvulsants, heat, obesity, and certain toxins. Of interest are certain commonly used drugs that happen to be folate antagonists, such as certain antibiotics, trimethoprim, anesthetics, such as nitrous oxide, and anti-cancer agents, such as 5-FU and methotrexate. In conclusion, significant progress has been made in the management of the spina bifida patient in the past few decades, and in particular in the past few years. These include improvement in hydrocephalus and Chiari care, prenatal repair, multidisciplinary care, and the initiation of transition programs. Scientifically, folate supplementation has been a major prevention success, and we've identified many environmental risk factors and made major advances in both molecular and cellular science. In the future, we look forward to improving the prenatal diagnosis and treatment, tethered code prevention, shunt technology, patient education, and optimizing national transition initiatives. In science, we hope to unveil optimal folate dose and schedule, as well as food fortification, clarify the correlation between experimental animals and human phenotypes, and identify the major causes of folate unresponsive NTDs. Functionally, we hope that a combination of nerve transfer and biomedical prosthetic technology will enhance the ability of spina bifida patients to ambulate and gain independence. Since the presentation is intended for the fellows and younger neurosurgeons, I dare to distill my slides into a few pieces of practical, though modest advice. As you start your practice, establish or join a prenatal care consultation clinic. Develop protocol for NICU management. Develop algorithms for the care of hydrocephalus, tether-cord, and syringomyelia. Join or establish a multidisciplinary spina bifida clinic and tailor a transition of care program that fits your institution. Then remember who we really are for the patients. As my partner Raheel put it, we're practically the patient's primary caregiver as well as advocate, since we understand best the complexity of the diagnosis and the patient, and embrace the social aspect of the patients and their family networks and use these relationships to educate. The myelomeningocele is the quintessential anomaly that helped shape pediatric neurosurgery into the specialty it is today. Starting with a few self-proclaimed specialists who committed to the care of the challenging patient population and studying their peculiarity, it evolved into a scientific and clinical crusade, requiring an understanding of embryology and science. Central to pediatric science is prevention, and the recognition of the effect of folic acid on NTD prevention is arguably the most important neurogenetics intervention in the past 5 decades. Spina bifida includes multiple neurological congenital anomalies that affect the function of many systems, benefiting from long-term multidisciplinary care in partnership with patient advocacy groups. The care requires complex congenital and fetal surgery and comprises age and severity-dependent diagnostic dilemmas. No other anomaly illustrates what a pediatric neurosurgeon does better than this one, and no other helped shape the field as this one has. I am indebted to many people for their advice and material, the speakers and the organizers, and most importantly, our patients and their families. We do it, of course, for them. Thank you very much.
Thank you, Dr. Iskandar. At this point, we'll move on to the discussion portion of the presentation. Afshin, you want to share your screen and start to talk about hydrocephalus, shunting, as well as ETV CPC. These talks will be between 3 to 4 minutes, with the main idea here being discussion and engagement for the audience. So please feel free to either engage me in the chat or unmute yourself to ask questions of both Dr. Iskandar as well as the presenters. Again, Afshin, take it away.
Sorry, I got unmute. Am I on mute now?
I can hear you. Go.
Okay, and you have the screen too? No.
No, I cannot see you. Perfect, you're up and running.
Okay, great. So I'm Afshin Salehi. I'm the current Pete's Fellow at St. Louis Children's. And here's the case of an antenatal diagnosis of a lumbar myelomeningocele of a patient with KRE2 finding on a 20-year-old mom who underwent elective C-section. This is a picture of the myelo on the day of birth. There's no CSF leak around the Plecode. This is the head ultrasound also on the day of birth that shows marked ventriculomegaly. This kid had macrocephaly, he had full fontanelle, and he had splayed sutures. He had no movement in the lower extremities except for some hip flexion with stimulation. And his OFCs were well above the 97th percentile. And so he underwent both a myeloclosure as well as a VP shunt placement at the same time, the same procedure. 2 weeks later, his head ultrasound shows some reduction in the size of the ventricles, and at 11 months, his MRI showed dysmorphic ventricles, but he's at 37th percentile on the OFC and has been doing well with no failures of the shunt. So the reason I brought that case up is because, unlike this case, all the cases that I've done during my training has been such that first the myelo was dealt with, and then the hydrocephalus was dealt with in a delayed fashion. And so the question that arose was, is there any evidence to show that you should do it at the same time or in a delayed fashion? And so I started looking into this, and this review from 2019 looked at 10,600 patients, and essentially in summary, it shows that there is a trend in treating the hydrocephalus in a delayed fashion over the last decade or so. And that looking at the rate of shunt infection or shunt failure, there's no difference when you compare the two, the simultaneous treatment or the delayed treatment. And also remember that not all the myelo kids will require CSF diversion. Some 80% or so of the postnatal closure and probably half of that of the intrauterine closures will need CSF diversion. And so the question is then, what do you do for surgery? There's options with shunting, ETV plus minus CPC. And so this HCRN paper looked at about 1,000 patients with hydrocephalus of all causes, and it showed that ETV-CPC after 1 year of follow-up had increased rate of failure compared to ETV and shunt alone. But then when you follow these 3 to 5 years out, the ETV alone had a non-significant trend toward lower revision, and there was less hospitalization. But again, this was all types of hydrocephalus and not specific to the myelomeningocele, which is what we're interested in. So Ben Worf in 2005 looked at this large prospective series in Uganda and looked at ETV-CPC rates and had about 66% rate of success with ETV-CPC and 47 or so with ETV alone. And these were older patients, and he was able to show that myelomeningocele and the non-infectious etiologies of CPC of hydrocephalus have better success rate as well. Then HCRN looked at the North American population, some 200 patients with ETV-CPC, and they were able to show about 50% success rate of infants at 6 months or up to 18 months. And the two independent predictors of failure were corrected age of less than 1 month and the post-hemorrhagic hydrocephalus causes. When they broke these down to types of etiologies for hydrocephalus as well as the age, then they found this interesting finding where you see the post-myelomeningocele hydrocephalus kids that were less than 1 month had over about 58% risk success rate with ETV-CPC. And if they were between 1 to 5 months, at about 62% success rate, and if they're older than that, had even more success rate than that. The aqueductal stenosis kids also showed a pretty good result with ETV-CPC. And so then the HCRN chose the rate of 40% as a cutoff for the subgroup that would benefit from ETV-CPC. And based on that, the recommendation was that for patients with myelomeningocele who are at least 1 month and have aqueductal stenosis, that ETV-CPC would be recommended. So there was a lot of data there in the short time that I had, but in summary, we talked about sort of the timing of treatment of hydrocephalus and show that there's a national trend over the last decade or so for treating the hydrocephalus in a delayed fashion after the myeloclosure. And as far as we know, there's no good data showing that you should do it at the same time. As far as the choice of the surgery, there's less consensus, and to me, it seems like it's a bit of an individualized decision. There's some data that shows more rate of failure with very young patients and better success in older patients. We saw that ETV-CPC in the HCRN was very effective, about 48%, even in less than 1 month of age. And so I think it depends on individualized cases. So to get a discussion going, I have a couple of questions there. I'd be interested to see what people will think of these. So, for example, would you do ETV-CPC on a 2 weeks old who has myelohydrocephalus? Would you consider that? I'm going to stop sharing this.
Dr. Limbrick, I'm going to pick on you first. What do you think? That patient comes into St. Louis, do they get a ETV-CPC?
I figured you might pick on me on that one. So I think right now, there's a randomized controlled trial to test that exactly through the HCRN called the SD trial. And so hopefully we'll have good data on that. I would say that, you know, of course it's individualized, but I think it's reasonable to offer ETV CPC if the anatomy is favorable. So that's something I would talk to the family about, risk benefits, the whole deal. But yeah, I think so. And the entry criteria into the SC trial at the moment are just changed recently based on DSMB meeting, but it's term infants with myelomeningocele or well, term infants with myelomeningocele. So I do think it's reasonable to offer it as long as you have a you know, a reasonable conversation with the family so they understand the risks and benefits of both.
Dr. Iskandar, same?
Well, maybe I would challenge Dave to something. Dave, what if the success rate is 30%?
Well, I think we have pretty good data that it's not.
No, let's say a different patient population has a success rate of ETV 30%. Would you consider doing ETV?
Well, that's a great question. So the success rate in post-hemorrhagic hydrocephalus was 38%. Yeah. And so I think most centers are now avoiding ETV CPC in young infants with PHH based on dismal success rates at you know, 38% in that case, I believe is the right number. So no, I don't think so. But again, you know, just like the MOMS trial, I think the best thing to do is to try to come up with high quality data. And that's what we're trying to do. But your point is well taken, Benny, which is where do you cut it off? And I'm not sure I really understand that. The other bit of data that I'll share is that from the Hydrocephalus Association, who did a survey of patients, and they asked the question, would you rather take a procedure that was less likely to be effective if it resulted in superior cognition? And the answer was they'll always take a procedure that's less effective, understanding that they may need a different procedure as long as cognition is stable to maintain shunt free. So I think I didn't do a great job on explaining that, but hopefully the point came across. But I think, you know, I do think in this population that it's at least a treatment option.
Yeah, just keep it brief, Dave. The reason I asked this question is really to just go back to Afshin and your point that this would be individualized. The issue is that if we didn't have anything called ETV and we were dealing with the shunt problems that we've been dealing with for decades ad nauseum with 40% failure rates at 1 year, and the complications of surgery. And someone came up with this bright idea. He said, look, I invented something called ETV, and I can make 38% of your patients shunt independent. Would that be taken in a different vein than now we've kind of taken it at face value that, hey, we can achieve 70% in this patient population, is 38% that bad? And, you know, I don't need an answer to this, but that's really I think the issue in terms of individualized decision-making and judgment.
All right, thank you very much. Let's move on to the second topic. Eric, I believe you're up talking about tethered cords, the bane of both my existence and many other people on the call. Talk about some of the data and ambulatory versus non-ambulatory children. Take it away, Eric.
Nice. Can you see my screen?
Not quite.
Yeah.
You're up. Good.
All right. So today I'm Eric Sribnick. I'm one of the neurosurgeons at Nationwide Children's Hospital, and I'll be talking about spinal cord tethering in myelomeningocele. So typical symptoms that are associated with spinal cord tethering following in myelomeningocele patients is back and or leg pain, progression of scoliosis, bladder dysfunction. Most concerning would be detrusor sphincter dyssynergia that's seen on urodynamic studies. And essentially that is where the detrusor muscle of the bladder is squeezing down on the bladder while the sphincters are still tightened. So instead of having the detrusor squeeze down while the sphincters are relaxed, they're squeezing down together, which causes urine to back up into the kidneys and can cause kidney failure down the road. And then finally, a decline in lower limb motor function. If you look at retrospective studies that have looked at large populations of myelomeningocele patients, you tend to find that about 10 to 20% of myelomeningocele patients are deemed at some point to have spinal cord tethering. On average, it can really occur at any time, and you can even see it in adults, but the mean age where most people are reporting this is anywhere from 6 to 9 years, which makes sense since it's thought to be most likely to occur around growth spurts. In most of your retrospective studies, the symptoms that we talked about are fairly subjective and seem to get better. The one objective finding is scoliosis. And if you have a patient with myelomeningocele who has progressive scoliosis and you perform the untethering prior to their Cobb angle being greater than 30 to 40 degrees, it's found that you can potentially arrest, if not improve, their scoliosis. Approaches to these surgeries. So first of all, ensuring that there is shunt function. There is anecdotal evidence that shunt malfunctions can present with findings that would be similar to spinal cord tethering. And since many of these patients are going to have a shunt, if they do, just ensure that their shunt is functional so that you're not missing a much easier fix for the problem. Also, because you're going to be opening the dura and you're going to be releasing cerebrospinal fluid, if you have a shunted patient with hydrocephalus who has elevated pressure above the foramen magnum and you are suddenly releasing pressure down below that, pressure differential can potentially cause herniation of the cerebellum and the brainstem. Goal-directed surgery. So there is, in myelomeningocele, certainly a wide range of function in these patients. In patients who are non-ambulatory, who have minimal lower extremity function, some people have advocated doing simply a spinal cordectomy. In folks who have preserved function, where they're ambulatory with braces or they're using their bilateral lower extremities for transfers, things like that, where you really want to preserve function, you would best be served potentially by performing more of a lysis of adhesions and carefully dissecting out the Plecode to allow the spinal cord to relax. In both cases, essentially what you're going to do is find the bony level, the first bony level caudally that appears normal, potentially take a little bit of that bone, find normal appearing dura, open the dura, and then work from rostral caudal down to your Plecode, either performing your cordectomy or very gently dissecting the Plecode from the posterior dura. Postoperative care, there was a Delphi survey study that was done in 2018, which essentially looked at postoperative care in these patients, for, preoperative care, intraoperative care, postoperative care. What they found was that there was only 80% agreement on 3 different things with postoperative care of this particular patient population. and that was that patients remain flat for 24 hours. It was recommended against using abdominal binders, and it was recommended that these patients receive 24 hours of postoperative antibiotics. So fruit for further research, where do we go from here in terms of trying to tease out the best surgeries for our patients? Role of urodynamic studies, it would be nice to have a very specific finding that you could really hang your hat on as far as which patients, based on urodynamic studies, require a untethering and which do not. Observation versus surgery. As I said before, the majority of research that I've read anyway is retrospective studies looking at large patient populations where they were operated on and seeing how these patients do. There's really only one study that I've seen in the Journal of Pediatric Neurosciences where they looked at about 40 kids, 10 of whom, all of whom had abnormal urodynamic studies, and 10 of whom received an untethering, about 30 who did not, and they found that the detrusor leak point pressure in those patients who had surgery was lower than in patients who were just observed. Neuromonitoring, which patients are best served by neuromonitoring, what are the indications for neuromonitoring, what are the potential benefits? In other similar pathologies such as intradural spinal lipoma, it suggested that you can perform a much more rigorous resection of these lesions with similar results to partial resection by using neuromonitoring. But there's been no real effort to look at which patients benefit most from neuromonitoring and how we're using it. Any comments, questions, discussion?
So these are types of patients that really drive us nuts over the course of the years and can be quite problematic, requiring multiple tetherings. I see Dr. Scott up there. Hello, Dr. Scott. You follow these for multiple years. Can you impart any wisdom on how you approach these patients, both ambulatory and otherwise, the role of urodynamics in making this decision? Dr. Scott, you're muted. You're muted.
You're still muted, sir.
Dr. Leonard, you might need to, I wonder if the crowd is muted. I don't know if Beth is still on. Is it from our end?
I think he's unmuted.
Yeah, can you hear me now?
We can, sir.
I'm so sorry. I mean, there's lots of fascinating things to talk about in this whole discussion. I mean, Afshin's this initial discussion about, shunting and repairing the myelomeningocele in one fell swoop. And in fact, I did that for years when I first started. And I liked the idea. I know that's not answering your question, Jeff, about untethering. But I just want to mention that since, Ben has come back and I've decided that it's far better to live life without a shunt than with it. And these Milo kids, has been mentioned by Benny and everybody, that the morbidity is so high with a shunt in. So that's just one point I want to make. The untethered issue, we published a series with neurodynamics.
Mike, we're losing you.
I'm sorry.
Yeah.
I've lost the link for some reason. I'm so sorry. But maybe you'll have to come back to me.
Yeah, you're good now.
Okay. We published a series of kids with neurodynamic studies, and they actually did pretty darn well with untethering in the Milo case. I was surprised at how well they did. And I like that indication. Scoliosis is not as didn't think in our group of patients. A lot of those kids went on to get disease. So like I think it's been mentioned already, these patients really have to be hard to get guidelines from the literature. There's so many different variables. Syringal hydromyelia, the malformation, the shunt malfunction, there's tethering, there's vertebral anomalies. There's a lot going on.
Yeah, absolutely. Thank you very much, Dr. Scott. Let's move on for the sake of time to Dr. Lauren Simpson, if she could, and then we'll talk about syrinx and put it together for the last part for a discussion at that point. Lauren, are you with us?
Yes, here I am.
Excellent. Thank you very much. And take it away.
Share my screen here. 1 moment.
Okay.
Okay, my name is Lauren Simpson. I am the pediatric fellow at Children's of Alabama, UAB. Can you all hear me okay? Okay, so this is a case of a boy who initially presented with a large lumbar myelomeningocele, which was closed on day 1 of life. And shortly after birth, he underwent VP shunt placement. He was symptomatic from his KRI2 malformation very early on. Unfortunately, at around 1 month of age, he actually developed a life-threatening intracranial bacterial infection, which he eventually recovered from, but this exacerbated his sick brain stem syndrome with stridor and difficulty with swallowing, dysfunction there. And despite bilateral functional EVDs, he still had clinical instability. So at around 2 months of age, his medullary dysfunction necessitated C1 laminectomy with intradural exploration to decompress his KRI2 malformation and reestablish CSF outlet. Intraoperatively, to achieve this, a dural opening was made at or slightly below the posterior arch of C1, and the fourth ventricle was not visualized, so a midline intraparenchymal conduit was established until fourth ventricular flow was visualized with subsequent egress of CSF. A couple of weeks later, tracheostomy and G-tube were placed. Although this patient lacked respiratory drive at night, he maintained some modest respiratory drive during the day. He did well over the next several months, and by 1 year of age, he began to globally decline again, and despite multiple interventions, he became completely ventilator dependent. A spine MRI was obtained, which showed worsening of severe syringomyelia with rather profound syringobulbia. He underwent a cervical laminoplasty for replacement of a syringal pleural shunt at that time, and he responded very well to that. Although radiographically he did not completely resolve, his syringobulbia decreased in size and he had symptomatic improvement. He remained clinically stable again until about 3 years of age, when he earned himself some imaging after presenting to the ED with a single episode of irritability. He was largely asymptomatic at that time, but MRI ultimately revealed that his cervical syrinx had markedly increased in size, and the appearance was comparable to what it was prior to shunt placement. At that point, there was concern that he could, although he was symptomatically stable, he could have catastrophic momentary brainstem failure given the degree of compression. So at that point, we decided on an incremental approach. The goal was improving the appearance of the syringobulbia radiographically. A plan was made to start with a shunt exploration and revision and then proceed to syrinx shunt exploration and revision if unsuccessful, with subsequent re-exploration of his KRI2 malformation and possibly spinal cord and tethering, above the level of the Plecode if that was unsuccessful. But he actually responded to the Syrinx revision and had no more neurosurgery visits for the next 5 years. He then presented again with progressive syringobulbia. This time he trapped his fourth ventricle. An EVD was placed to gain more control over cerebrospinal fluid dynamics, and he underwent a redo QRE2 decompression with placement of a fourth ventricular stent to the cervical subarachnoid space. And he has not required any intervention over the past year. From the literature, we know that symptomatic QRE2 malformation is the most common cause of death in infants born with myelomeningocele. Approximately 1/3 of infants born with myelomeningocele will develop symptoms of brainstem and lower cranial nerve dysfunction, and up to 1/3 of these patients will die as a consequence of symptomatic QRE2 malformation. We know that age at presentation is not correlated with outcome. However, severity of brainstem malfunction is. And the extent to which surgery can reverse the course of symptomatic QRE2 malformation varies, but early detection and intervention offer a greater likelihood of recovery than intervention undertaken once severe symptoms and profound deficit have occurred. Some controversy exists as to whether the primary insult to make QRE2 symptomatic is related to compression and downward traction of the brainstem and lower cranial nerves, or if it's a manifestation of a dysplastic brainstem in the setting of dysraphism. But there's consensus that a good first step, a necessary first step, is making sure that the CSF dynamics are taken care of and the hydrocephalus is managed. As it relates to QRE2 malformation, if the insult is more related to compression, then it can be indicated in some cases, but there's less consensus about this. The concern, at least part of the concern, is a high mortality rate associated with symptomatic QRE2 malformation and whether or not the symptoms will actually resolve. So this case, along with others encountered this year, led me to question what the best treatment algorithm for children with symptomatic QRE is, what the role for QRE2 decompression is versus placement of a Syrinx shunt, for example.
I'll throw it out there to Jeff. I see you're on, as well as Jim. Your role of QRE, what are your thoughts about QRE2, its role? Because as I've gotten older, the numbers of QRE decompressions has gotten significantly fewer and fewer. And so I wanted to see sort of where you guys are with that.
Yeah, I think we would share that perspective, Jeff. First of all, Lauren, that was a nice presentation, and for everybody else, that was a bit extreme. That's not a typical sort of, that was unfortunate, one of our more unfortunate kids. I think Benny's presentation was typically outstanding. And I would just, in answering this, I would go to what Benny said in the sense of like the normative distribution curve, the classic Gaussian curve. Kids that have QRE malformation that are symptomatic, the vast majority will respond to CSF dynamic adjustment, either alone or nearly alone. And at least in Birmingham, the number of times that we're considering that disease a disease of space confinement rather than weak link in the chain is a decided minority. And I think this speaks to what Jeff Leonard was just saying about the pendulum definitely has swung to CSF dynamics being central. So the number of QRE malformation decompressions that we've done has decompressed over the, decompressions that we've done has definitely decreased over the years. And now it's, I don't want to say a fourth down and 40 kind of play, but it's close to that we try and do everything we can with CSF dynamics first, space constraints second, and then only then do we think about us decompressing the syrinx. One last point is that if you decompress a Chiari-2, it is not a brain and skull operation. It is primarily a cervical operation. You have to be exceptionally careful because the torcula drops in Chiari-2, and there have been examples of well-trained, very well-intended surgeons opening right into the torcula with catastrophic results. So be very attentive if you're going to decompress Chiari-2. Know where the torcula is and consider it a predominantly cervical, i.e. C1, maybe C2 type thing operation. Thank you, Jeff.
And just to clarify on what Jeff was saying, when he says CSF dynamics, he means fix the shunt. That's what that means. So not put a stringo-pleural shunt in or some other, more extreme intervention.
Spot on, Jim. Thank you.
Jeff, I'd like to make a comment here. I'd like to join the chorus here that says that that we don't need to operate on Chiari-2 malformation much anymore, but I'll take it one step further, and I will bring back something that my former partner, Leon Albright, used to say, is that the Chiari-2 surgery is of historical interest only. I have not decompressed a Chiari-2 malformation in 17 years, whereas we used to do several a year. Now, I don't have the practice that UAB does. The thing that bothers me is that when you look at the literature in terms of types of decompressions, some people do bone only, some people do duroplasty, and they have the same results as the ones that they do the extensive, very sophisticated procedure that was described here. And that doesn't make sense considering the foramen magnum is large in these patients. So there is not only a conundrum between, is this a dysmorphic brainstem versus is this a mesodermal problem, but then there is significant disagreement about what to do with those. And not based on, in Chiari-1, you would say, well, the posterior fossa is small, the primary procedure is to enlarge it. That's not the case here. It's important to mention this because these lectures are gonna be seen over and over again. It's important for people not to think that Chiari-2 is a basic operation that that we do routinely.
I think that's a really important point. And to just add one more small point to it, we were surprised a few years ago when we did a simple survey of people's practice preferences and practice patterns of the number of people that were still performing Chiari-2 malformation. So I would submit, taking Benny's point, that there's still a fair number of people out there, a surprising number of people out there that are still considering this to be a regular part of the armamentarium. But I think at the experienced centers that are really in the trenches of wrestling with this, this is a lecture series intended for the fellows. And the predominant message should be that the trend is definitely very strongly away from surgical decompression of Chiari-2 and predominant fix the shunt, deal with CSF dynamics. That's the prevailing and increasingly embraced thought and point of view.
Yeah, and just to reiterate their points, I mean, I've been in practice for 10 years and I've done one Chiari-2 decompression, and it didn't help the patient. So I think that's a good way to think about it. I agree with Dr. Iskandar and Dr. Blount.
May I make a point too here?
Yes, sir.
This is Mike Scott in Boston. I think, there are Chiari-2s and there are Chiari-2s. I mean, some of these kids, as you all know, they have incredibly disordered brainstems anatomically. They're stretched and there are incredible deformations present. But in some of them, although Benny said the foramen magnum is large, the posterior fossa itself is very squat and short, and sometimes things are really crowded and pushed, and the foramen magnum region is very crowded, just like a Chiari-1. So again, I think it's hard to have a definite hard and fast rule about not operating on these, as was shown by the cases that the fellow presented. Was it Lauren? I forgot that Lauren presented. I mean, there was a trapped fourth ventricle there, and all the measures that were done to try and relieve that pressure failed, and something else had to be done. So I do want to make a point that these cases have to be individualized again. And I also would add, I hate syrinx to pleural or peritoneal shunts. We've had terrible luck with them. And that's something I haven't done in 30 years, but to each his own.
Thank you, Dr. Scott. And last, Sandy, I see you up there. Do you have any comments on this?
Thanks, Jeff. You know, we were just texting back and forth that that yeah, in 15 years, I've seen I've done 2 Chiari-2 decompressions. So I just echo the practice trends, and really, you know, looking at the classic papers of actually from Pittsburgh with Dr. Albright and Dr. Pollack, and then the updated literature from Alabama, and later on, it really just supports that, you know, I'm not sure that we can beat natural history with surgery, but definitely with Dr. Scott's points that, you know, sometimes we do, right? Like all of us are saying, the number isn't 0, it's low, but it is patient dependent. So this was a wonderful set of lectures to really spark discussion. So thanks.
Thank you, Sandy. All right, in the interest of everybody's time, since it is now almost 8:20, I'd like to thank our lecturers, Dr. Iskandar, Afshin, Eric, Lauren. I'd like to thank the discussants and the participants and everybody for attending this lecture. I would also like to make a point to say the third lecture is Dr. Adelson talking about epilepsy that will happen in approximately 2 months, which you guys will see announcements for coming out here over the course of the next month and 2. Thank you very much for your attendance, and hopefully any suggestions, please feel free to forward them, because the idea here is for education and to provoke these kinds of discussions amongst our group. Thank you very much.
Thanks, Jeff.
Thank you, Jeff.